All right, let's dive into some pretty complex territory today. HIV coding.
Yeah, looks like someone sent us a stack of materials on this.
Don't worry, though. We're going to break down the key guidelines for you.
From the Absolute Medical Coding Institute's Medical Coding Guidelines Manual.
You can find a link to that in the description, by the way.
Absolutely.
So we're going to try to give you all the need-to-know info without getting too bogged down in jargon.
Sounds good.
One thing that really stood out to me is AMCI's approach in this AMCI manual.
Yeah.
It's all about simplifying those intricate ICD-10-CM guidelines.
Right.
They even have this clever flip and tap system.
It's a really cool way to navigate the guidelines quickly.
Exactly.
Yeah.
So are you ready to tackle some real-world scenarios?
Absolutely.
Like what happens when someone has HIV but they're admitted for a broken leg?
Interesting.
Or how do you code asymptomatic HIV versus a full-blown AIDS diagnosis?
Yeah, those are important distinctions.
We're going to cover all of that and more.
All right, let's get started.
So the first guideline focuses on confirmed cases.
This is crucial. We only code HIV, which is B20, when there's a confirmed diagnosis.
Right, not just based on lab results or suspicion.
Exactly.
So documenting HIV positive is very different from just saying possible HIV, right?
Huge difference. It underscores how important clear documentation is.
Yeah.
Coders rely heavily on those provider notes.
To accurately reflect the patient's condition.
Precisely.
All right, so confirmed diagnosis check.
What about sequencing those codes?
Guideline number 2, let's break it down.
Okay, so this is all about the logic behind sequencing.
Yeah.
It depends on the primary reason for the admission.
Okay, so give us an example.
Sure. Imagine a patient admitted with HIV and pneumocystis pneumonia.
Okay.
In that case, we would sequence B20 first, followed by the code for the pneumonia.
B20 being the HIV code.
That's right. But now, let's say someone comes in with a broken leg, and they also happen to have HIV.
Ah, so the HIV is not the main issue this time.
Exactly. So we'd sequence the code for the broken leg, which is S82.001A first.
And then the HIV code after.
Correct.
Makes sense, right?
Yeah, it's like prioritizing. You put the main problem first and then the secondary.
Exactly. It's like telling a story, what's the main plot?
And then what are those subplots?
Sequencing helps paint that complete picture of the patient's health.
Okay, so we've talked about confirming cases and sequencing, but what about those times when someone's HIV positive, but they're not showing any symptoms?
Yeah. How does that affect the coding?
I'm looking at guideline number 3 here,
Okay.
which seems to tackle this very issue.
Right. So that's where the Z21 code comes in.
Okay.
It's specifically for individuals who have a confirmed HIV diagnosis,
Uh-huh.
but aren't experiencing any symptoms
Okay.
or related illnesses.
Yeah.
Imagine someone comes in for a routine checkup.
Right.
Their HIV status is noted, but they're feeling perfectly healthy.
Oh, okay.
That's a classic Z21 scenario.
So it's like a silent code almost.
Yeah. It acknowledges the presence of HIV without any active issues.
Right.
But wouldn't that make things tricky?
Yeah,
If they come in later with an HIV-related illness,
absolutely.
would you still use Z21?
That's a great question. And that's where the guidelines emphasize the importance of accurate documentation and the patient's current state.
Okay.
If someone with a history of Z21 coding develops an HIV-related illness,
Right.
like Kaposi sarcoma or pneumocystis pneumonia,
Okay.
we shift back to B20 for subsequent encounters.
So it's not a one-time Z21 assignment.
Right.
It's dynamic and can change based on the patient's health evolution.
Exactly.
Fascinating. Now, what about situations where the test results aren't so clear-cut?
Okay.
Guideline number 4 seems to address this.
Ah, yes. The realm of inconclusive serology.
Right.
This is where the R75 code steps in.
Okay.
It's a bit of a placeholder used when test results are uncertain
Uh-huh.
and there are no definitive symptoms or diagnosis of HIV. It acknowledges the ambiguity while further investigation is needed.
It must be unsettling for patients to be in that limbo state.
Absolutely.
Knowing something's up but not having a clear answer.
It is, and it highlights the importance of patient counseling and support during this phase.
Yeah?
R75 is a temporary code, and further testing and monitoring are crucial
Right.
to reach a conclusive diagnosis.
Okay, shifting gears a bit.
Okay.
Guideline number 5 throws a curveball
All right.
by stating that once a patient has a confirmed HIV diagnosis, even if their current visit is for something completely unrelated,
Right.
we still use the B20 code.
Yeah.
Why is that?
It might seem counterintuitive, but it's all about maintaining a comprehensive and accurate medical history
Okay.
by consistently using B20.
Okay.
We ensure the patient's HIV status is flagged in their record,
Right.
regardless of the reason for their visit.
I see.
This can be vital for future treatment decisions and understanding potential interactions with other conditions.
So even if someone with HIV comes in for a broken leg
Exactly.
or a routine dental checkup, that B20 code stays put.
Yep.
It's like a permanent marker in their medical record, highlighting an important aspect of their overall health.
That's a great way to put it.
Okay.
Now, things get a bit more intricate when we factor in pregnancy.
Okay.
Guideline number 6 dives into the specific coding considerations for HIV-positive pregnant patients.
Pregnancy always adds a layer of complexity, right?
It is.
It's not just about one individual anymore, but two lives intertwined.
Right.
What are some of the key points here?
The main takeaway is the use of the 098.7 code series.
Okay.
This signifies that HIV is complicating the pregnancy, childbirth, or postpartum period.
Wow.
It's a crucial distinction that captures the unique challenges and considerations in managing HIV during this time.
So we'd start with R98.7.
Right.
And then follow it with either B20 or Z21.
Correct.
Depending on whether the patient is symptomatic or asymptomatic.
Exactly.
I'm imagining a scenario where a pregnant patient in her second trimester comes in for a routine prenatal checkup.
Right.
She's HIV positive and on antiretroviral therapy, but doing well otherwise.
Okay.
How would we code that?
You're spot on.
Sure.
We'd sequence it as follows.
All right.
098.7 to indicate HIV complicating the pregnancy. Then B20 for her confirmed HIV status.
Okay.
Z3A.17 for the second trimester.
Wow.
And finally, a code for routine prenatal care, like Z34.81.
Wow. That's a string of codes.
It is.
But it paints a very detailed picture of her situation.
Right.
Ensuring all aspects of her care are accurately represented.
Exactly.
It's amazing how much information these codes can convey.
It's like a secret language that healthcare professionals use to communicate and document patient care.
Right.
It might seem complex at first, but once you understand the logic and the guidelines, it becomes a powerful tool for ensuring accurate record keeping and data analysis.
Speaking of a secret language,
Okay.
guideline number 7 seems to delve into the different scenarios surrounding HIV testing.
Right. This is where we break down the why behind the test.
Nice.
Is it routine symptom-driven or part of a follow-up? That will determine which code we use.
So for routine testing, like someone getting their annual HIV checkup, we'd use Z11.4.
Correct.
But what if they're getting tested because they have symptoms
Okay.
that could be related to HIV?
Then we prioritize the symptoms in the coding.
Okay.
For example, if someone comes in with fever, fatigue, and swollen lymph nodes,
Okay.
we'd first code those symptoms using codes like R50.9, R53.1, and R59.1. Then we'd add a code for the HIV test itself, even if it's negative, to capture the reason behind the testing.
It makes sense to focus on the presenting issue first.
Right.
And then the test as a follow-up.
Exactly.
But what if the test results are inconclusive? We touched upon this earlier. But how would that be coded?
Good catch.
Okay.
If the test is inconclusive, we'd still code the presenting symptoms first.
Okay.
And then use R75 to denote the inconclusive serology.
Gotcha.
This acknowledges the uncertainty and emphasizes the need for further testing and monitoring.
Okay, so we've covered routine testing.
Yes.
Symptom-driven testing. And inconclusive results.
Right.
What about situations where someone receives counseling after a negative HIV test?
Okay.
Is there a code for that?
Absolutely.
Okay.
Z71.7 covers counseling related to HIV testing.
Okay.
Regardless of the test result.
Gotcha.
It encompasses pre-test counseling, post-test counseling, and risk reduction education.
Right.
It's all about ensuring patients have the information and support they need to make informed decisions about their health.
So even if someone tests negative, they might still need guidance and support to navigate their anxieties and understand how to stay safe moving forward.
Exactly.
Z71.7 captures that essential aspect of HIV care.
Exactly. It's not just about the test itself, but the holistic approach to patient well-being.
Okay.
Now let's move on to guideline number 8, which deals with the ongoing management of HIV with antiretroviral medication.
This seems pretty straightforward.
Yeah.
You'd use B20 for the HIV diagnosis?
Correct.
And then add a code for the long-term drug therapy.
You're right on track.
Okay.
We'd use B20 for the HIV diagnosis and Z79.899 to indicate long-term drug therapy.
Right.
This combination captures both the presence of HIV and the ongoing efforts to manage it through medication.
It's a powerful reminder that HIV is no longer a death sentence.
Right.
With effective treatment, people can live long and healthy lives.
Absolutely.
And this code reflects that positive shift in the landscape of HIV care.
Absolutely.
Okay.
And this brings us to our final guideline, number 9, which focuses on HIV prophylaxis.
Okay.
Specifically pre-PP.
Pre-P has been a game changer in HIV prevention.
It has.
It's incredible how a single daily pill can significantly reduce the risk of infection.
It is.
How do we code for encounters related to pre-P?
We use Z29.81 to denote pre-P encounters.
Okay.
This code captures both the prescription and monitoring of this preventative medication,
Right.
just like with other scenarios. We might also add codes for any relevant high-risk behaviors that might be factored into the decision to prescribe pre-P.
So if someone is prescribed pre-PP and they also report having multiple partners, we include a code to reflect that risk factor.
Correct.
It's all about painting a complete and accurate picture of the individual situation.
Exactly. These codes might seem like small details, but they have a big impact.
Right.
They tell a story of individual health journeys and contribute to a larger narrative of HIV prevention, treatment, and care.
It's fascinating how these codes can weave together individual experiences and broader public health trends. It's like piecing together a giant mosaic. Each code representing a tiny tile that contributes to the bigger picture.
That's a great analogy. And by understanding these codes and applying them accurately, we can ensure that the mosaic is as clear and complete as possible.
Okay, so we've tackled all 9 guidelines.
We have.
And wow, there's a lot to absorb. I feel like we've only scratched the surface, though.
You're absolutely right. These guidelines are just the starting point. There's so much more to explore and understand within the ever-evolving world of HIV coding.
Before we wrap up this section, I'm curious about something.
Okay.
We've talked about the importance of accurate documentation, but what are some specific things coders should be looking for when dealing with HIV-related cases?
That's a crucial point.
Okay.
First and foremost, coders need crystal clear documentation of the HIV diagnosis itself. We only use the B20 code for confirmed cases. If it's still being investigated, we code based on the presenting symptoms or reasons for testing.
Right, because using B20 prematurely could skew data and create confusion down the line.
Exactly.
Okay.
We also need a detailed picture of the patient's clinical status.
Right.
Are they asymptomatic or are they experiencing HIV-related symptoms or complications?
That will determine whether we use B20 or Z21.
You got it.
Okay.
And of course, any treatment or management for their HIV, like antiretroviral therapy or prophylaxis, needs to be clearly documented as well to capture those additional codes.
It's all about connecting the dots.
Yes.
The patient's presentation, the services provided, and the corresponding codes.
Precisely. And don't forget about social history information.
Okay.
High-risk behaviors, for example, can influence code selection.
So it's like detective work, gathering all the clues to tell the complete story.
That's a great way to think about it.
Okay.
Comprehensive documentation is the foundation of accurate and informative coding.
Which ultimately impacts patient care and public health data.
Okay, so as we move into the final stretch of this deep dive,
all right,
I want our listener to really grasp the power they hold with this knowledge.
Absolutely.
It's about so much more than just assigning codes.
It is. By understanding and applying these guidelines correctly, they're playing a vital role in ensuring the accuracy and integrity of medical records, which has far-reaching implications.
It really is amazing to think about how these codes impact everything, from individual care to public health trends.
Absolutely.
And ultimately driving better outcomes for everyone.
It's really quite remarkable when you step back and think about it.
It's like we're looking at a giant web. Where each code is a thread connecting different aspects of HIV.
A complex, interconnected system.
And that system is constantly changing.
Absolutely. It's dynamic.
With new treatments,
new guidelines,
new prevention methods emerging all the time. Exactly. And that means the coding has to keep up.
So this deep dive has given us a good foundation.
A good starting point, for sure.
But it's clear that staying current with HIV coding requires a commitment to ongoing learning and adaptation.
You have to stay curious. New guidelines come out, new codes are introduced, and even the way we interpret existing codes can change.
So it's not just about memorizing a set of rules.
Right.
It's about understanding the logic.
Absolutely, the reasoning behind them.
And being flexible enough to adapt as the field evolves.
That's the key to really mastering this.
So for our listener who's been diligently following along,
hopefully taking notes,
what's the most important thing you want them to take away from this deep dive?
I'd say it's this. Remember that HIV coding isn't just about numbers and letters on a page. It's about people. It's about lives.
It's about making a real difference.
Exactly. Every code you assign contributes to a bigger picture, a picture that helps researchers, public health officials, and healthcare providers make informed decisions about prevention, treatment, and care.
It's like you're part of something much larger than yourself.
You're helping to shape the future of HIV.
That's pretty powerful stuff. So as you continue your journey in the world of HIV coding,
yes,
remember that you're not just deciphering codes.
You're not.
You're contributing to a healthier future for everyone.
And that's something to be incredibly proud of.
Absolutely. And don't forget, you can find a link to the Absolute Medical Coding Institute's MCG manual in the description.
Right.
That'll be a valuable resource for you as you dive deeper into this fascinating world of HIV coding.
Absolutely.
So keep learning. Stay curious.
And remember,
your work truly matters.
It does.
Thanks for joining us on this deep dive, and until next time.
Yes, until next time.
Keep exploring.